kind of bonus material. So we can do that later on if folks are interested and if there's still time. But that we can ignore for now. You'll be focusing on the artificial flesh. Okay, thanks to PRN. They're the ones that supplied all this equipment. So please, if you haven't done so already, visit their booth. They have awesome stuff. The sutures are theirs, and they have other awesome products as well with their company. So I'm a huge fan of them, and I've been doing these suture labs with them for a couple of years now, and they're really cool. So a little bit about me. I graduated from Cornell University in '06. I then performed a 1-year general internship in Boston in Massachusetts. After that, I became board certified in surgery. I did my training in Long Island veterinary specialist in New York. After that, I moved to Las Vegas for warmer weather. I practiced in a specialty hospital for about 9 months. After that, locum surgery around the country for about a few more months. And then from there, I managed 3 hospitals in Silicon Valley area in 2018. From there, I became part owner of a hospital in Studio City. I managed surgery, internal medicine, and oncology there. And then currently, the past 6 years or so, I've been operating Vet Triage, which is an online telehealth platform. If you have any questions about telehealth, feel free to ask and let me know. This is our outline for today, a lot of stuff. This suture lab, it's hard to figure out where folks are expertise-wise. Some of you have never even touched surgical instruments before. Others have been doing this longer than I have and know all these things. And so trying to make this kind of a wide breadth is challenging. So some of you might be somewhat bored, and maybe this will give you a chance to kind of refine some of your skill sets, maybe some words of wisdom, because we all develop bad habits over the years. And for those who are really new at this, if you need extra help, let me know. Or if I'm helping somebody else, help each other as well. I have plenty of folks in these classes that end up helping the other people at their table also. Something as simple as holding needle holders that we're used to, someone else has never done it before. So I try to make this where it can kind of satisfy everybody, all levels of expertise. This is our list of topics that we're going to tackle here. And as we get towards the bonus material stuff, these might be things that are more either advanced, let's say, or that the prosthetic is not really the best for without a real patient. But we'll do the best we can to kind of teach you some cool things after that. But I want to make sure that you at least have the fundamentals down packed. So when you leave here, you feel a little more comfortable with practicing some of these techniques, either on cadavers or maybe in real patients, depending on where you're at in your skill set. Again, thank you to PRN. This is Kevin. He's awesome. He's usually here helping me as well set things up, and he's great. And so check out their booth and tell them thank you. And then Dr. Miller, who used to give this course before I took over, he supplied all these videos. So Dr. Champ, he really helped me out with all these awesome videos that we have. So these are all his material that I'm going to leverage for you guys. Okay, so we're going to start with some basic principles. Before we start operating on our patient here, we're going to talk about some basic surgical principles. Most people are right-handed. If you are left-handed, you have to accommodate. I hate to tell you, but for right-handed surgeons or left-handed, just mirror image, this is how you typically are going to hold the needle holders. So you've got the ring finger here, and then the thumb is in this handle, and then your pointer finger is meant to help stabilize the direction of the needle holders, and then the middle finger is trying to minimize the stress and pressure for the rest of your hand. So you want this grip to be really comfortable. You're not looking to grab the instrument with all of your might. If you imagine doing a 2-hour surgery, holding instruments with all of your might, you're going to fatigue. It doesn't sound like it's just your hand, but it will translate to a lot of pressure. So you want to be comfortable holding the needle holders in this way without having too much stress. They have to kind of sit there, you're controlled, but you're not forcing the issue. You can also palm it, where you have the majority of this instrument in your palm. A lot of large animal vets will use this technique, but and if you want to use that, you're welcome to, of course. We're going to be focusing on the standard, I guess what I call a standard way of holding needle holders. So that's how we're going to hold these. And then for the thumb forceps, kind of like a pencil or a pen, this is how you're supposed to hold them. You don't need a lot of pressure. This is surgery. It's supposed to be controlled, effortless, efficient. You're not looking to put a lot of pressure on your hands, so you're holding it like a pencil. The blunt part of the instrument is sitting nicely in the crevice of your hands there, and your fingers are arranged like this. You're not trying to like pinch and put too much pressure on it. You shouldn't need it. And these are Brown Adsons, so this is the one that hopefully you have at your tables with the tiny teeth. When it comes to standing in the OR, again, this may not mean much for this class, but when you translate this to the operating room in your hospital, How you stand there is going to contribute to your fatigue. It's very stressful to have to stand over the table and you're kind of leaning over. It's not good for your neck, for your back. You may not think about it in surgery. You'll feel it later. You'll feel it when you get home. It'll creep up. And if you're doing surgery for years like this, it's going to be a problem for your overall posture. So you're not looking to stand over it. This gentleman here is a bit tall. You might want to raise the table and try and have your arms a bit more relaxed position. You want them at about 90 degrees. You don't want to be forcing yourself over the patient like that. So either, if you're a really tall person, you either can heighten the table more, or you spread your legs so that you lower yourself more. And that way you're not hunched over. You can be at the level of the patient. So either raise the table or lower yourself. If you're a shorter person, then of course you can either lower the table or grab one of those like footstools. And usually they have pretty comfortable coverings on them for your feet, because you're going to be standing there possibly for hours. All this stuff adds pressure to your upper back, your lower back, your neck, back of your skull. You'll feel it. And so you want to make sure that you're at a nice comfortable position, right angle to the table. You're not doing this with your neck. It feels good to do it because it feels like you're focusing, but it's not helping you. And you want to make sure you're at right angles to the table, and you can just effortlessly do your thing. Okay. Any questions, by the way, just feel free to shout out or raise your hand, and this is an open forum. This is meant to be quite interactive. So let's go into suture types. The goal here is we're trying to repair mucosa, subcutaneous tissue, or skin, and these take days to heal, versus fascia repair can take weeks, tendons can take months, of course bone takes years. There's a degradation profile with how we characterize suture. So there are other types, but these are most commonly used in veterinary medicine, are those that degrade over time. They're absorbable suture. The degradation profile tells you how quickly over time that suture is going to degrade in that patient. And those are factors that are both external to the patient, like the suture, as well as the patient environment, the bodily environment. Is there infection there? What kind of tissue are we talking about? Is it stomach, intestine, bladder? The structure of the suture determines whether or not it's going to be absorbable or non-absorbable. And if it is absorbable, the structure will dictate how long it'll last in the patient, combined with environmental factors. So broadly speaking, there's two different types of structure for sutures. The monofilament, which is just one strand, and then the multifilament or braided, which is like braided hair. And so with monofilament, you can imagine, has less tissue drag, meaning when it goes through tissue, it goes smoothly through it. It doesn't get hung up as much like you would with braided, where it has all those crevices and it can get hung up in the tissues. Similarly, because monofilament is usually nice and smooth, it doesn't have any crevices to harbor bacteria or organic debris. It's also less likely to cut friable tissues because it doesn't have those crevices where it's going to create like a saw pattern. Whereas with braided or multifilament, it is more likely to harbor bacteria or organic debris and can cause a bit rougher, have a bit rougher touch on the tissues. But we like braided because it has easier handling and good knot security. It really ties nicely. Most folks that I know of, we almost never use multifilament or braid anymore. I know some surgeons for intrahepatic port systemic shunts, they'll use this because they want the extra security and they want the inflammation that occurs with the absorption of the suture. But most of us are using monofilament sutures. How many folks here use multifilament or braided suture? Yeah, there you go. This is more academic nowadays than actual use. So determining your suture type depends on the type of tissue you're trying to repair, how long you want it to last in the tissue, and then of course that's based on the environment of the patient as well as the suture material. Ideally, when you pick suture, you want the smallest adequate diameter. Remember, suture is foreign material, so it's going to create a reaction in the patient. That patient's body is going to want to reject it, and that's going to show up as inflammation. And so we want to minimize the amount of foreign body you have in that patient, but you also need to be large enough that it's going to secure that anatomy. So if you're dealing with fascia, for example, which is a very annoying tissue to heal, it's going to take at least weeks to heal. You want something that's strong enough to handle that fascia, and most fascia is around joints. So you're going to pick a fairly large diameter suture, even though you know smaller is better for the foreign body reaction, but the patient has to heal too. So there's that balance. Same thing with trauma to the patient. The larger your suture, the more trauma you're placing, right? Because the bigger hole it's creating to be inserted. Plus, if you're trying to cover like a big thick knot underneath some very delicate cat skin, you can imagine that knot's going to rub on that skin from underneath. That also is trauma and inflammation that you can avoid by using smaller suture size. So less foreign body less foreign material in the body. Okay, We're almost there, then we'll do some hands-on stuff. So absorbable suture can be further divided into how long you want it to last. There's short term, so there's typically mucosal sutures in the face of oral surgery, skin sutures, especially in young animals. You get 6 to 7 days of wound support with complete absorption in about 2 months. And so here are some examples from PRN suture. Then there's kind of like in between for general closure, skin, subcuticular, muscle, stomach, intestine, uterus, bladder, and 14 days of wound support. They go away in about 2 to 3 months. So here are some examples. And then long term for general closure, subcuticular, cardiovascular, same viscera, and then wound support 35 days, about a month, and it takes about six months or so to dissolve, and here are some examples. So it all depends on what you're trying to achieve with that patient. You want to absorb as quickly as possible, but you don't want to absorb before the patient's body heals. All right, our first lesson here, starting very basic, the square knot. The square knot is the most frequently used knot. It is most secure, least likely to unravel, not great in areas of tension. So we're going to define this word tension here. When you put two wound edges together, the amount of pull, the propensity for that wound to want to separate again, that's tension. And so if you have too much tension when you close it, it means that you're stretching those tissues and they're meeting, but it's under a lot of pressure. That's not good for the patient. It's going to cause tissue trauma, and also it stresses out your suture where it can like cut through or break. So you want to try and figure out, you're trying to minimize tension. You're always trying to minimize tension. Sometimes you can't because of the way the anatomy is. We're going to go through some patterns for that. But in general, you're trying to minimize tension. And so square knots are not the best for areas of high tension. The way these videos are going to work, I'm going to explain the knot or the pattern in words, which will be kind of pointless for those who don't know this. But in the video, we'll go through it, and I'll replay the video multiple times for you. I'll also have a drawing in between the words in the video so you can kind of see. So just bear with me with the words, because it won't make sense right off the bat, but once you do see the drawing in the video, it'll make more sense. Square knot consists of 2 simple throws, with the second simple throw in the reverse direction of the first. Both throws must begin with the needle driver between both strands of suture. Think of both sides of the suture as a circle. For those who are very new to this will be a common theme when I come around the table. We're trying to stay inside the circle. You'll see in the video what that means. If it helps, just watch the short end of the suture. It has to go side to side, start on one side, go to the other, and back and forth. So this is what we're looking for. This is a square knot. So you're going to take a bite, you're going to place the needle into the tissue, come around, exit, and then you're going to form this like pretzel shape. So you're going to form a circle and then tie it. So this is an example of a square knot. It's also called a throw. You're placing one throw. Here's 2 throws. Here's one square knot, here's another square knot. So we're going to go through these here. I'll show you the video a couple times, and then when you guys are ready, we can now start to practice. Pick an incision on your prosthetic, and you're going to do a square knot. So watch the video. If you already know how to do this, feel free to practice it. Otherwise, this is what we're going for here. Dr. Miller is taking a bite on one end of the wound, going across the wound, coming out. Now he's going to show you here the circle. This is the circle we're trying to create to make that square knot. Circle, grab the other end, the free end, and then come across. You see how we formed that pretzel shape, and then came across. Do again a second throw, the opposite direction, circle, and pull it through. I will replay the video several times for those who want to watch it a few more times, and I'll keep it playing until we move on to the next example. These principles here are very, very important. This is the foundation for everything that you do. And so for those of you who already performed these surgeries, bear with us. This is very basic. For those who've never done this before or just starting, this is fundamental to everything that we do, is going to be starting off with a square knot. So I'll play it again. And again, keep in mind how he's holding the needle holders, right? The way we showed you in that picture. Takes a bite, goes across, forms a circle, goes to the other end, grabs it, and it comes through. Oh, got you. So, no, it's all good. It's all good. I can hear Lynn. Okay, yeah, you need this as well. Yeah, this too. This should be good. There's one prosthetic. Yeah. You have that one? Yeah. You have suture here too? Okay. Suture, yeah, so let's do, this is 0. We'll try 3 though, if you want bigger or smaller, let me know. There we go. So here's a 3 ohm. And then here's 2 3 ohms. And you have about 4 sets, needle holders, and suture scissors? Yeah, some are very stiff, so if it's bothering your hands, you know, yeah. So it's all kind of new, so let's just see what. Some of these also like, sounds like maybe crappy too, so the scissors, man. Well, these are all used ones, I don't know if I'm using them. Some of them do, some don't. It has some. You do? Okay. Machine scissors too? Okay. Okay. Yes. Oh, good. Okay. Let me replay the video. So this is square knot. How many folks use square knot routinely in their surgeries? Those who do it. Okay, good. So I want to make sure everybody gets this, because this is the foundation for everything. So if anyone, I'm going to come walk around now and see who needs help with it. No, do it. Yeah. That's good. Yeah. We'll do cruciating in a few slides. So it's all good. Play it again. Yes, you also notice too with the prosthetics, there's a lot of tissue drag. So when you pull up on it, the prosthetic comes up with you. So yeah, bear with. That's not how it would be, of course, in real life. But yeah, it's good. Seems like folks. Does anybody need help with this one or more time with the square knot? Seems like we're pretty efficient with it. Okay, good. I'll mention a few other things here in the next couple of videos too, some things you may not have thought about for those who are more experienced with suturing.
So that's something that I do when it's not
Yes.
locking down.
Yes.
Is I make it into a slip knot and then get it down to, you know what I'm talking about?
Yes.
And go back.
Yeah. So a slip knot is, so if you were to, let's say you were going to do this, sorry, it's hard to replay it. So if you notice when Dr. Miller does this, he'll place, he takes a bite, goes across the incision, takes another bite, and then he forms a circle. Can I pause this? Yeah. Oh man, it's so annoying. It's so annoying. Because in play mode, it makes the mouse disappear. Right? Oh, you can see it there. It's very annoying. They can just fast forward to it. So when he does that, you can see here he's putting equal pressure on both sides of the knot, right? So here and here has equal tension on both sides. A slip knot, you'll put unequal pressure. It'll make your knot slip down more to one side. It won't be exactly over the incision. And some folks will do that if they're working in a deep body cavity. It's just easier to do that. Or like she's.
With this really monofilament, it does not lock down.
Yeah.
You have to do something.
Yeah. So you'll find that when you suture these on the prosthetics, it may not cinch down itself the way it would like in real life when you've got like real skin and debris and plasma and all that stuff. Yeah. But yeah, you can do the slip knot too to try and help secure the knot further. Yeah. So don't think it's you if you're making your knot and it doesn't look as tight as Dr. Miller's or in real life. It's because the material we're using is just not optimal. See how it's nice and tight? You might see some of yours are kind of like loose. So, okay. Let's go. This is one point I want to make here. If you notice when Dr. Miller took the bite, he went on one side with the needle, went all the way across to the other side. I would encourage some of you, especially those who are a bit more experienced with it, instead of going from taking one bite where number 1 is and going right to number 4 across the incision, instead take your first bite, exit completely out with the needle, and then re-enter to go to the opposite side. And if you do it that way, if you exit first and come back through, you are not forcing a curved needle to go in a straight line. It doesn't matter here because the prosthetics are small, but if you're trying to cover a wide wound gap with a needle and you're making it go straight through, you risk bending or breaking the needles. You're trying to make it go straight when it's really a semicircle, it's a curve. What this also lets you do when you exit and then re-enter, it lets you oppose it more. You can choose where you exit and enter to make your bites a bit more even, a bit more symmetric. So keep that in mind too. I'll emphasize this in the next video as well, but the nice little tweak you can perform to improve your cosmetics and your frustration in surgery too. So this is what I use most frequently is a surgeon's knot. It's also known as a friction knot. Again, I'll just explain in words, and then next will be a picture and then the video. A surgeon's knot is often used in high tension tissues that cannot be properly opposed using a square knot. The surgeon's knot differs from the square knot due to an extra pass through the loop of the first throw, double overhand knot followed by a single overhand knot. I'll show you in the picture in the video. This extra twist in the first throw provides more friction to maintain its position until the second throw is placed. And so you're going for this. So basically what we did before with the square knot, it's like you're doing 2 square knots before moving on to the next throw. So that you're looking for this type of shape, and then once you perform the surgeon's knot, which is this, or also known as a friction knot, you can then support it with your second throw being a square knot that we just learned. So I'll show you here in this video. I like square knots, and then you're going to find it better for this material because it'll probably sink down more on the material. It's more secure for the prosthetics. So repeat what we did before. Take a bite from one side, go across to the other side. Now he's going to do the circle, but he's going to do it twice now. So make your circle twice. See, looped it around twice, and then you get that more convoluted pretzel shape. And then in the second throw is a square knot, like you did earlier. You'll feel this one be a bit more secure on your prosthetics because you've got the square knot, which has more friction, and then your surgeon's knot, which has more friction, and the square knot will further support it. I'll play it again. Here it is again. How many folks here use surgeon's knots? Yeah, almost everybody. Yep, good. How many folks here are veterinarians? The majority. Any technicians? Yep. Okay. Yeah. Oh, okay. Yeah. Great. Excellent. I'll play it again, and I'll emphasize what I emphasized before with the needle leaving the wound and then re-entering back in the wound. I think it's a good technique to get yourselves used to it. For those who've been doing surgery for a long time, maybe get reacquainted with that. For those who are just starting, it's a good habit to start now. It is a bit slower to exit the wound and then re-enter it, and you don't always have to do it. Once you get proficient in surgery, you can figure out when you want to use it. But I think for better surgical technique, especially if you're just starting to learn, what you're going to want to do is you take your first bite, and then instead of going across like he's going to do now, you exit the wound and then re-enter the opposite side and then exit. And I prefer that in certain scenarios as opposed to just going straight across. This especially is helpful if you're repairing like a wound on a very large dog. It's a wide wound gap. It helps you to not force the needle across. You want to exit and then re-enter. I'll play it again, then I'll come walk around and see how you guys are doing. And again, these are foundational principles for those who this is their first time learning it. This is paramount that we master this stuff as best we can before moving forward to the patterns and things we're going to do here. Okay, let's see what you guys are doing. Are you finding that the knot is more secure with this one? Yeah. Some of you already have simple interrupted down.
When we were talking about the square, we were talking about slipping it down like in the cavity with the pressure. I just don't know I tried to do something like that.
Yeah, exactly. Yeah, because and pulling, you're pulling. Keep tension on this one. Pulling. Let me see.
Oh, so tension is
Yes.
and pull.
Yeah.
I
The idea that one hand is deep in the cavity, the other is yep.
I got it, okay, thank you.
Imagine working on a liver like by the diaphragm where you're doing a diaphragmatic hernia repair. You're stuck there. You're trying to push that.
Okay. But the tension comes from this whole thing is
Yeah.
sliding,
Yep.
sliding out.
And
Okay.
then you want to reinforce it with another throw. Yeah, so it's triple. Yeah, so I had done 3 throws or 3 rounds, but instead of the 2 with the surgeon's knot. I've done it with cases where it's the most common case I do a lot of these with, the more frustrating cases are you've got a large dog, you remove the big sternal mass, and the damn dog keeps laying on at home, keeps opening up, and you're using 0 suture size, you're using Proline or whatever, something that's not absorbable. So I'll do 3 throws to really fight that tension. It's a crude way of trying to avoid having to do something like releasing incisions or skin grafts or crazier stuff. You can get away with just closing it primarily. But yeah, I've done 3 as well for extreme cases like that, which is very, very annoying. Yeah. Yep. Is there a name for it, by the way? I never actually looked up. Do you know if there's a name for that, for doing 3?
Name for it?
Yeah? I just looked that up.
I don't.
Triple magic. There you go. Coined here. Anyone need help with this one? Are we okay? Yeah. All right. So this is our first pattern. Many of you have already done this, knowingly or unknowingly. You've already did this on your prosthetics, but we'll go through it. Simple interrupted pattern maintains tissue position and strength if one portion fails. Minimum holding power against stress. So again, maybe not the best for high tension. It requires more time, it requires more suture. Certainly if you're learning incision closure for the first time, this is of course the ideal one you're going to start off with, because let's say you place these sutures and this one kind of sucks and it fails on you. Well, theoretically if this one fails, the other 2, as long as they're good, should hold the incision together. You won't have the entire thing fail because one suture didn't work out. And so this is basically what a lot of you have already done, but this is placing 2 knots in a row, whether you're doing surgeon's throw followed by square knots or just all square throws, doesn't matter, it depends on you as the surgeon, but we're just going to depict this here. You're going to do whatever closure you want to start off with. Ideally, again, I would say exit and then enter, or you can go across depending on what your opinion is. So he's showing the circle again, he's going to do his, I think he does a square knot, yep, he's doing a square knot here, and then he's going to reinforce it with another square knot. See how nicely the tissue edges come together? Here you go, cut that. Now the tag length, depending on, oh, it definitely does? Okay, I was going to do another one. I guess not. So simple interrupted would be a bunch of these in a row. I thought he did more of them, but that's okay. So you're just going to do another one again. They don't connect to each other, they're all separate. Tag length, so how long you leave the suture tagged when you cut it, kind of depends on like where you're working in the body. So for example, if you're performing intestinal surgery, you like to have smaller tags because the omentum and adhesions are going to form and because of those tags. But you don't want them so small that they're going to like slip. either. So it takes some experience to know like how long you want it. You can read the books and they'll tell you whatever millimeters, but it depends on your experience level and what part of the body you're working at. The example I gave before, where if this knot is going to be underneath some ferret skin or rabbit skin that's very thin, again, you want small knots because it's going to rub against the underneath portion of the skin for a delicate animal. But then there's other situations like that big dog with the sternal mass that you may want to have long tags because that's already failed on you once. The dog's going to put a lot of pressure on there. You want to minimize any risk of the suture knots loosening on you. So it kind of depends on what part of the body. Also, if you have to remove the sutures and it's very annoying to grab them, right, at suture removal, have long tags. Don't piss off your staff by having short tags there. Nobody wants to fight with that. So long tags if you're trying to remove them. So you use your judgment for that. Okay, this is one of my favorite suture patterns, is the cruciate pattern. So this is two simple interrupted sutures placed parallel to each other and tied across incision. This is the X shape, cruciate shape. It's an appositional pattern, which we're going to talk about, and good for low to moderate tension, so a bit stronger. The security is similar to simple interrupted, but it's faster. And Dr. Miller likes using it for cat body wall. So let's talk about appositional, what that means. There's three types of closures you can perform. When you have two wound edges, you either can close them in an appositional way, meaning they oppose each other perfectly. They're flat head-on, right? Appositional. That's usually what you want. There are some scenarios where you choose the other two, but typically you want appositional. It makes sense. There's also inverting, where you're purposely making it where the suture ends are inverting. It's tucking in. You use that for two-layer closures, for example, like uterus or stomach. You're going to have an inverting pattern. It allows for extra protection of the viscera. And then there's eversion, where it goes upwards. It does like this kissing thing. It goes up, and so that you rarely want to purposely use that. Sometimes you do because you want there to be adhesions forming, but typically you don't. And so eversion for areas like small intestine will create more scar tissue or more adhesions forming because the mucosa is exposed to the abdominal cavity and the body doesn't like mucosal exposure. So that's eversion. So there's eversion, inversion, and then appositional. And that's what we're talking about here. We're going to do some inverting patterns later on for those who are interested, but appositional is typically what we're going for. So here's cruciate. So with the cruciate pattern, you're taking a bite like you normally would, exiting, but now instead of doing your square knot or surgeon's knot, you're going to come back to where you started, parallel, and then repeat. And so that comes through, and then you tie them together. And you're either going to use a surgeon's throw or a square knot, typically because you're using cruciates for high tension areas or moderate tension. I'm usually going to do a surgeon's throw, so I'm going to do the double and not the square knot, but you can choose. Here's a video of it. This is one of my favorite patterns because it is very fast. It does take up more suture material in case you or your boss cares about that, but you're trying to do this for faster surgery or for areas with some tension. It's a very strong pattern, and hopefully when you're practicing on your prosthetic, you can appreciate how strong it is compared to the ones we've done so far. This is the cruciate. So you take a bite, one end to the other, and then go back, start again parallel to your first bites, exit, and then you tie them together. Like I said, I probably would use a surgeon's throw in a real patient because you're typically doing this under moderate to high tension and you're trying to go fast. So I'm trying to just get it done, but it depends on what you want to do. So you see you're forming that X shape. So he did a surgeon's throw, grab it, and then you form that X there. And you should feel the tissues opposing very nicely together. It should be a lot stronger than the pattern we've done so far. How many folks use cruciate pattern in their practice? Boy, we got a bunch of pros in this room. Uh-oh. All right. We'll get through it. We'll get through it. Yes?
Question.
Yeah.
How many throws do you like to typically do for skin sutures like this?
Yeah, so how many throws? So just to remind folks, again, the throw is when you're forming that first knot, that's one throw, then your second knot is another throw. So it depends on the body type, it depends on our body location, it depends on what suture material you're using. Typically, most of the time, 3 to 5 is what you're going for, 3 to 5 throws. If you are working in an area like small intestine, you want to maybe a little bit on the lower side. If you're closing up some thick laryngeal paralysis dog skin, then I'm probably going to do like 5 of them. If I'm repairing a cranial cruciate ligament tear using a prosthetic, I'm probably going for like 5 of them. So it depends on what you're doing. Thoracic surgery, I'm going for 5 because I can't have any risk of failure. You don't want any risk of failure for anything, but you have to balance what we talked about before with the foreign body material and the bulkiness of that suture knot with what you're trying to achieve. So 3 to 5 typically, depending on what suture pattern or what suture material you're using and what part of the body you're working at.
Thank you.
Yeah. Trying to think if there's any other rules for that. Yeah, if you look at any textbook, any surgery textbook, they usually have a chart with like the type of suture material and what they recommend. But just realize when they say those things, it is up to your opinion based on where in the body you are working.
Do you have a rule of thumb for distance between simple interrupted sutures?
Yeah, so the question is, do you have any guideline or rule of thumb for how far apart you place the sutures? So you're going to hate my answer. It has to be just enough. It has to be just right. That's based on experience. So I never like the idea of like, let's say you're finishing up your enterotomy and we want to poke in between with like the tip of the hemostat, because I can always poke through it. There isn't enough suture in the world that I can place in there to not poke through it. And maybe I'm a bit more aggressive than most, but still, it just never made sense to me as a rule. And so if I'm seeing nice apposition, it looks and feels pretty secure, then I'm okay with that spacing. If I'm incredibly nervous, maybe the tissue that I'm repairing just has questionable integrity to it, then maybe I'm placing more than I normally would in between them. But if you look at the textbooks, they will tell you how far apart they recommend any location. But I tend to go based on how it looks and feels at the time of the surgery. There is, of course, such thing as putting too many sutures too close together as well, right? Because if you're working with like a ferret's intestine, you only have so much room before your own sutures start causing tears in the intestines, right? And then you're in trouble. So you can't think of it as, well, more is probably better. That's not going to be the case. You have to go based on your experience level with practicing this stuff. But a few millimeters typically, but it depends on what part of the body you're operating at. Anybody need help with cruciate? I don't want to, yes?
I have a question.
Yeah.
For like a cystotomy or looking at the bladder, would you generally place more sutures on that one? The tissues one?
Because they expand.
Yeah.
So the question, if you're doing like a cystotomy, like urinary bladder surgery, would you want to put more sutures in there because that's viscera, it's going to expand. So theoretically, all the hollow organs are going to expand to some degree, but of course, urinary bladder is a very tight expansion, right? But usually, with an organ like urinary bladder, you're going to perform a 2-layer closure, and typically your first layer might be a simple continuous pattern, and then your second layer is going to be inverting. So you have 2-layer closure, which is more protective, and also has some room for expanding, but also the inverting pattern, because of the way it is going to help promote adhesion beneath the surface. So you're going to get that seal quicker than if you hadn't done inverting. And also the uroepithelium takes, within 24 hours, it's already formed a seal. So it's pretty quick. So in general, because of all those factors, we tend to be safe enough and good that way. If, however, so I've had some screwed up urinary bladders where it's like I can't do continuous. It's so friable. Every time I pull, it tears, and I have to interrupt it. Then I use the same rule as I would for stomach or intestine. I place just enough sutures so where it looks and feels good. The other thing I'm going to do too, the protective measures, I'm going to attach omentum to it. So if I can easily take the omentum from the cranial portion of the abdominal cavity, retract it caudally, I'll do typically at least 2 sutures, ideally 3 to 4 sutures, and tack it over that incision. That's going to provide another layer of protection to help with sealing it. Yeah. Yeah, because you're right. Because you can't plan for the expansion, right? You can, you're trying to do the best you can considering the circumstances. But the body is so good at healing this stuff, and uroepithelium, especially within 24 hours, is forming a seal, assuming you didn't mess up badly or the tissue it was necrotic or something like that. And you can also keep it purposely empty too. If you place a urinary catheter, for example, then the bladder will never get full because you have a urinary catheter. And so if you're really worried about about a uroabdomen, you can place a urinary catheter in there because you know within 3 days, 3 to 5 days, it's going to seal up. Knock on wood, assuming the bladder is healthy. So you can actually purposely keep it decompressed by passing a urinary catheter if you really were worried about your closure. Okay, next one, horizontal mattress. So the horizontal mattress pattern starts by creating a simple interrupted pattern, but instead of tying the suture, the needle is inserted some number of millimeters laterally on the same side as the needle exited. It crosses to the other side of the incision to exit directly across, 6 to 8 millimeters lateral to the first site of entry in the skin. It'll make more sense if you haven't done this before. It'll make more sense in the pictures in the video. The suture ends should be both on the same side of the incision or then knotted. It's good for areas of tension. So here's another theme, more tension. Good in skin, can cause eversion if not applied correctly. Could cause microvascular disruption as well, but you can prevent this with other surgical techniques that we're not going to talk about here today, but there are ways. And so let me just show you what we mean by that. So this is a horizontal mattress. You take a bite, go across. Now, unlike cruciate, where cruciate you would have came back around, take a bite and gone across, with horizontal, take a bite, go across, then on the same side, go back the opposite way, and then you tie it in. So you can see the suture knot here is now offset, right? It's not over the incision like the cruciate pattern was. This is offset. So the reason why Dr. Miller mentioned microvascular disruption is because blood vessels typically will go perpendicular to the incision. And so you can imagine if you're creating this ring, it's cutting off blood supply that's entering the skin or whatever tissue this is. Now, thankfully, because of collateral circulation and robust vascular supply, this typically is not a problem. But if you do this either in the wrong area where there's not a lot of blood supply, or maybe it's too close together, these knots, then you might be at risk of causing an issue with the vascular supply to the animal. So here's a video showing it. So taking a bite on one side, going across. Now he's going to turn the needle around, stay on the same side. And the same length, the same distance from the incision to where your first bite was. It's the same length, and then go across. You're going to exit parallel to where you entered, same length from the wound. Makes like an H pattern, and you'll feel now when you tie this, and you're using a surgeon's throw. You see that he's using a surgeon's throw because these are usually higher tension areas, so you want to have that extra strength. And you should feel this part here. You should feel it tuck. It should tuck in. You should feel that pull. It may not be as well. Actually, it should be somewhat obvious in the prosthetics. It'll pull through, and that's what you're going for. That's how you know that's a strong suture pattern. It's also why microvascular disruption is a concern, but you'll be able to feel the strength when you close it. Let's replay it. So again, take a bite. I would advocate for exiting and then re-entering. Just get in the habit of doing that. Turn it around. Now, ideally, again, you see Dr. Miller's using his fingers to hold the needle. Theoretically, you'd want to use like your thumb forceps to hold the needles. The instruments you have in your hands should be an extension of your fingers. You really shouldn't have to use your own fingers to move stuff and touch stuff. You're not only increasing the chance of infection, you're also increasing your chance of poking a hole through your glove. It's also more fatigue for you. It's more work for you. Your instruments really should be the extension of your fingers. It's hard in this environment because your patient is moving around, right, with the prosthetics. But you want to imagine that you can't use your hands at all. You want to use your instruments to act as your hands, as your fingers. So, but we all do it. I do it too. We get lazy. It's just quicker, and we just do it. And, but if you want to learn the proper technique with our non-viable patients here today, then it's a good time to practice it. I'm gonna do it one more time here, and then I'll come around and see how you guys are doing. How many folks have used this pattern before? What areas would you use it typically? What did you find it useful for? Do you remember? Any idea?
If I was just really nervous about, like, skin,
far near ones, but that'll be next. I use this for like joint closure for like stifle, if you're doing a cruciate surgery, yeah. Or if you're doing patella luxation or you're worried about some patella laxity, this helps pull the joint capsule over to really keep the patella in place, but yeah, otherwise, maybe I'm using this in that example before, that like big dog with the sternal wound, and it's failed. Maybe I need to do this, you know, but yeah, otherwise I'm using it for fascia, for the stifle. Yeah, and you should be able to feel that pinching when you tighten it. You should be able to feel that pinch there, which tells you did it right, and it drives the point home that this is for tension areas. You feel it pulling it through. If I am using this pattern also for like skin or something like that, I'm probably only using it like once here and there. And then in between that is going to be interrupted or cruciate or whatever. Yes?
So for this one, since it's for areas generally with like higher tension, would you leave the ends longer?
So the question is, would you leave the ends longer so you're using this for areas of higher tension? Not necessarily. It's the same rule from before, but chances are, unless you're using this in a part of the body, you're not going to remove the sutures, like the stifle, for example. You're going to leave it long just for the ease of your staff to remove them later. That's really pretty much it. As far as the patient goes, I don't think it matters as much, but like you were saying earlier, well, I'll use it if I'm nervous about something. Well, then leave the tags a little bit longer. As long as you don't think the longer tags are going to hurt the patient in any way, then leave them longer if it makes you feel like it's more secure, so you don't get any loosening. Okay, next up, vertical mattress. So the vertical mattress pattern involves entering the needle some millimeters from the incision line on one side and exiting on the other side of the incision at the same distance. Next, the needle is turned and entered 4 millimeters, so this is half the length. I'll show you. From the incision line and exited half the length from the incision on the opposite side. The suture ends are then tied. This is a tension pattern, stronger than horizontal, less tendency for eversion. I like this one also more than horizontal. And again, it could cause microvascular disruption as well. This is what we're looking for. So the picture is hard to describe, but you're taking a bite here, you're coming across, turn the needle around, and you're entering in between. So halfway between where you exited and where the incision is, halfway between when you go across the wound and exit out the other side, you're going to exit in front of where you entered, in between. Okay, I'll show you the video. The drawing is not great for, it's a little crooked, so he'll show you here. So for this one, I encourage you to start farther away. That way you have room to work. So start farther away from the incision, and again, you're going to see now how hard it is to push the needle across, because you're forcing it to go. See how he's struggling with it? That's why I think you should exit first and then re-enter. You will prevent this struggle. See, this is now bending the needle. You could break the needle. It's just not worth forcing it like that, but that's an FYI. So he takes a bite on one end, exits, now he turns the needle around, and then he's entering in between. See, in front of where he exited, halfway between where he exited and where the incision is, and then he's exiting the opposite side in a similar way. See that? So it's all in the same plane. It's in one line. It's in one line. It's a vertical mattress, one line. And notice the direction now of the part that's being pinched, because you'll feel this part dimple. Before, with the horizontal, it was parallel to the incision. Now it's perpendicular to the incision. And also you can see why this would disrupt the microvascular tissue less. You're not strangulating the vasculature. It's parallel to the vessels. Even though it can cause disruption, it's much less of a risk, which is why also I think more and more people like this one too. So try to play it again. This is the one you might hear people call it far, near. It all depends on your distance from the wound.
Do you recommend surgeons go for this one as well?
Oh, so the question is, do you recommend surgeons throw up this one as well? I do, because it's still a tension area. Let's see what Miller does here. I don't know if did you notice what he did here? I didn't catch it. But I would do surgeon's throw. When you're working with area of high tension, then you want to maximize the strength, you know. He does a surgeon's throw also. You know.
So you want your first bites to also be deep then, right? Since you're coming back in above the same tissue, you stay too superficial.
Yeah, so the question is, you want to take deep bites, so you don't hit your own suture when you come through. Yeah, probably. I haven't had that really be an issue. You don't want to necessarily grab the underlying tissue, unless that's your goal, but I can't believe that would be your goal anyway. But you do want to make sure that you're not incorporating anything deeper. Boy, I don't know how to do the video. Yes. Oh, there it goes. Okay. Yeah. I mean, you should feel again the tension when that dimple to tell you that it's pretty strong. Yeah, I see some of your prosthetics are starting to elevate because of the tension. Yeah. And by the way, if folks want, if you're looking to do this again at home, we're going to send you home with your own prosthetic too, a mini prosthetic you can practice. I do post these videos on my YouTube channel as well, so feel free you can rewatch this whole thing again at home. I'll have my YouTube at the end of the talk, but I've posted these before, so you can practice at home too if you want to revisit all these things. Good. Okay. Move on. Yes. Yeah. Yeah. What's up?
At a GP level,
Mm-hmm.
when do you think a vertical mattress would be indicated?
Yeah. The question is, from a GP standpoint, when would you use this? I don't know. One of you folks used it. If anybody here uses from, yeah.
Hope I never needed it.
Yeah. Yeah, again, if I'm doing high tension areas, I'm typically going with cruciate pattern. And if I'm using the horizontal mattress, I'm using it for stifle surgery. This one, maybe for a back patella luxation, I'm using it on the joint capsule. But otherwise, maybe if it's a really frustrating wound that's already failed twice before and you're running out of options, maybe you'd use it for that. But otherwise, I'm not really sure when you would use it. Yeah. Trying to think of whether or not it would be helpful if you have the crotch of an incision, where the incision has that kind of V-shaped thing, and you're trying to. But even then, I'm using a cruciate anyway, because you can incorporate all the edges at the same time.
I'll take it.
Okay, simple continuous. So another pattern. This starts with a square knot, one diagonal pass and one perpendicular pass. If the needle advances above and below the skin, that's a running suture, which is not as good. Minimal tension holding, good apposition, good seal. So this is the urinary bladder question from earlier. Relatively fluid and airtight, and I actually use this on enterotomies. I'll do it with intestinal resection, anastomosis. The stomach, the first layer of the stomach, we'll use this as well. We all use it for body wall and skin incisions, but if it breaks, the whole thing's gonna fail. So this is a simple continuous. You start off the way we started in the beginning. Take a bite, go across, take another bite, do either a square knot, either a surgeon's knot followed by square knots, or all square knots, do 3 to 5 throws, and then instead of cutting both tags, you will continue to the other side and repeat. Go, 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 go. And then when you're finally done, we'll close it. And so this is a simple continuous pattern. This is if you're beginning with surgery, just learning how to do stuff. You're a bit more advanced than just doing simple interrupted. You feel like you can get a little faster now. This helps you be a bit more efficient with the surgical time. But you have to be secure in your ability to create the knot and to maintain tension as you're moving along the incision. You can imagine if these are like, for example, intestines and they constantly move, your pattern might loosen as the intestines are moving, for example. Or if you're getting kind of loosey-goosey with it, you're not going to realize you've been loose the entire time until the very end, and they have to start all over again. So you start with your basic square knots or surgeon's knot plus square knots. And now he's only going to cut the one side just to make the tag shorter. But instead of cutting the other side, like you would normally for like a simple interrupted, you're going to take the needle and then repeat. And same question from before, how much spacing do you have? You definitely want this to be all equal. You want to enter and exit ideally at the same distance away from the incision like you did from the previous bites, but this number of millimeters all depends on what part of the body you're working at. If I'm doing a simple continuous pattern for like urinary bladder or small intestine, I might be much closer, I'm going to be much closer than if I was doing this, like for example, for the linea alba.
So you don't worry about suture failure with simple continuous on an intestine?
Yeah, so the question is, do you worry about suture failure if you're doing simple continuous on like the intestine or any kind of hollow viscera? I don't, because I've done so many with interrupted that at some point I feel comfortable playing with simple continuous. I would only advise it if you've done a bunch and you're like, okay, I get it now. And even for like, for example, let's say you're doing intestinal resection, anastomosis, and you're doing simple continuous, I'm probably not doing it continuous the entire way, maybe a quarter of it, and then restart again. Quarter of it, restart again, quarter of it, restart again. That's no more, that's just more like, it's just more annoying to do it all the way through, because the intestines, you have to rotate it, and I'm trying to do things without an assistant in there, so it's really more for my convenience than it is for any medical reason, but yeah. But you could argue that if you did simple continuous for an enterotomy or for anastomosis, that you're creating a stricture. And that's the concern. Yeah, the concern is you're creating a stricture. I wouldn't do it for like a rabbit or for a ferret or for a cat. I'm only doing this for like larger viscera. So a big dog or stomach or bladder. Yeah, because you are at risk of creating a stricture if you're doing it for like a really small lumen. So I'll play it again. We'll see if folks need any help with ending this pattern, because we haven't reviewed how to end the closure. I think, do I have a picture? No, I don't. Okay. We'll do it again. Once it gets close to the end of this, I'll slow it down, and we'll talk about how to end a pattern, a continuous pattern like this. Because there's some piece of advice I want to review for those who have done that before, and for those who haven't, you may benefit from seeing it step by step. And again, I'll emphasize, try not to use your fingers, try to use the thumb forceps to hold on, to grab the suture end to cut it, and try to use your thumb forceps to place the needle back in the needle holder. And the same thing here, you can either go straight across, or you can exit and then re-enter. Another thing I also will say too while we're watching him do this, if you decide that you want to enter with the needle and just go straight across and exit, when you do that, I would place the needle in a semicircular motion. So it's very easy to force this to go straight through as if this needle is straight, but it's not straight, it's semicircle, or similar to a semicircle. So I would take a bite and then when you pull it out, pull it in that same semicircle fashion. That way you follow the root of the needle. It's these little things that'll stop annoying things from happening to you in surgery. you know, if you're using like 4.0 PDS or something like that, it's very easy to bend those needles. Yes?
When you're coming out in the middle before continuing to the opposite side, are you re-grasping or you're just kind of seeing the needle and then putting it back?
Either way, whatever feels natural, wherever you end up while you're doing it. The goal of these things always is to try to minimize touching the skin, even though your staff prep the skin for you. Trying to minimize touching the skin. Trying to minimize having the needle and other things touch the skin so you don't promote bacterial migration in the skin, and also you're trying to avoid your own hands, your gloved hands from touching stuff. So and also the more you contact the needle, the more you contact the suture, the more damage you're causing to these things as well. Again, this is me being very picky about it, but whatever feels comfortable when you get there is what you do. There's no hard rules with this stuff. It just comes through with whatever it is you feel is most efficient for you, and minimizes iatrogenic infection and trauma to the tissues and to the instruments you're using. I'm gonna reverse this to go to the loop part of this. So for folks who need this, so when you're about to close it, you're trying to finish this. He's creating a loop. So right there, he's got a loop, and he's going to close it. So now instead of pulling it all the way through the way you did before, he's making this loop bigger. So he's got a big loop there. Now he's going to create his, I think, square knot. He's doing square. He's doing surgeons. So surgeon's throw, and he's grabbing that loop, and he's pulling it through. So similar to how we started this, but now you have an extra thing on the side. Ah, damn it, this thing. It's so annoying. Right there. So now you have a loop on this side. Instead of when you started, you only had a strand. Now you have a loop. So similar to when you started, but now you have a loop here. And so you pull that through, and then you grab the other end like you normally would, doing a square knot now. We started with the surgeon's throw. Now he's doing a square. Grab the loop, pretend the loop is a strand. Grab the loop, and then go through, like you would for any square knot. It just looks weird because you have a loop on this side. But that's how you end these. And then repeats. Grab that side, square knot, boom, square knot, boom. So that's how you'll end that part. I'll go through some more pointers in a little bit here, but for folks who are doing this for the first time, that's how you end. Does anybody need help with that part, with ending it? Yeah. Maybe play the video for everybody, and I'll come over there. Isn't that annoying? That's what people hate. I love these, but that's what people hate. Okay, so let's say you're at your. Okay, so now you form a circle. Like this one. We don't have to, but you're going to most specific. There you go. Nice. Good. Just square knot now. But yeah. Perfect. Yep. Yep. Exactly. There you go. Yeah. No problem. Now notice this part got a bit loose there. And then in the next one, I'll talk about how to like tighten it up more. Yeah, but that's how you do that. It's perfect. And if folks want to, you can also practice with smaller suture or larger suture. We have 0, I think 2.0, 3.0, and 4.0 suture sizes. So let me know if you want a different size. Try 4.0. I don't know there will be too much drag, but see what you think. Do you guys have these at your table or no, the smaller ones? Oh, okay. Yeah, no, those are the ones that you supposed to take home with you after we're done here as a gift, but I'm only seeing one, so let me text them. Let me text them. Make sure we have, I know, fight to the death, who wants it? Okay, so I'll text them after this one. So, next pattern, forward interlocking. So admittedly this one I don't really perform. It is considered more like a large animal pattern, but I know plenty of small animal doctors that use this. It's very useful, very strong, and very fast. So forward interlocking. So it's a modification of simple continuous pattern. Each passage through the tissue is partly locked, which is what makes it strong, linked to the previous passage through a created loop of material. At the end, the needle is reversed, the knot is tied to the loop left in the suture material, good apposition, good stability. So this one, if it does break, even though it's a continuous pattern, it's still likely to stick together. But you're using way more suture and it is harder to remove, although again, I've heard mixed opinions on this one too. I've taken just like anecdotal surveys in these classes and some folks think it's actually easier to remove. So it just depends on what you think. But this is what we're looking for here. It's like doing a simple continuous pattern, but instead of exiting outside the circle, you're exiting inside the circle. See how you have a circle here, but the needle is exiting inside of the circle, inside of it, not outside. And you get this locking pattern. Looks like pi, 3.14. So here's a video for this. Let me text them about the thing. Okay, so standard, I'm going to assume you use a surgeon's throw and then square knots, and now he's taking a bite on the other side. But just like simple continuous, except this time he's inside the circle. See, he's inside the circle. He's not outside of it like we did before with simple continuous, he's in it. And that's what's creating what I call the pi sign, the forward interlocking. So again, opposite end, takes a bite, comes through, and he's going to exit inside the circle, inside the loop, not outside. If you did outside, you'd be simple continuous, but you're doing it inside, so you get forward interlocking. Very cool pattern to play with, fun. You can feel it. You can see how he puts tension on this side as he does the next one. You can feel it lock. You can feel the strength in it when you have a forward interlocking. So it's quite a secure knot or a secure pattern. How many folks use this in their practice? Yeah.
So my
Yeah.
doctor uses it a lot on dental closures when he's just like, I'm tired of this.
Forward, yeah. Do you, and well, I guess for dental, you're not removing the sutures then, they're just.
They're just all.
Okay. Yeah. For folks who do use this, is it annoying for the staff to remove it or for you to remove them, or pretty quick?
I'll leave them in.
Leave them in and they just fall out over time? Yeah.
But yeah, I usually use it for like
would you ever use this pattern anywhere not external? Not that I know of. Anybody have a different opinion on that? Yeah. Would you ever use this for any part of the body that's not external? Yeah, no, no. I've never used it outside of like vet school, myself, but yeah, I've only seen this being used externally. It's usually the oral cavity or skin is how I've seen it done. Or I've heard about it done. And usually for the oral cavity, small animal, sometimes skin for small animal too, but large animals, from what I've heard anyways, it's always been skin.
Is it good for like a big dog spay type of a thing?
Yeah, like a big dog spay.
Attention?
Yeah. This would be, so for folks who are new to this one, but have done plenty of surgeries or at least wound closures, this might be a fun one to practice on when you get home from the conference, because it's pretty straightforward and it's just kind of a cool new way of trying something, and you can see how you like it. Just make sure to maintain tension the entire way. You don't want it to be loosey-goosey. If it gets loose on you, then it kind of defeats the whole purpose of it. Uh-oh, okay, there are no kids to take home. Boy, I should not have told you until I confirmed. I saw it, I was like, oh, okay, good, we have them. And then I just realized only one. All right.
So it is a fight to the death.
Yeah. Like, okay, there's a coup now. I spell coup, C-O-O. What is it?
C-O-U-P.
At one point, I knew that. See, sorry guys, I shouldn't have said anything until I knew. Boy,
We just take the ones we're playing with now.
epic fail. They will not let me. I did that one year. I didn't know that. That was the one. They would not let me do it. I can ask them. Actually, I can ask Kevin. I don't care. It's not my stuff, but
It's like we have to make the other group use the used ones.
Say it again. Sorry.
The next group, they have to use the new used ones.
I never asked them what they do with the used ones. But after the courses, they always like come by, and the PRN people, they take out all the sutures you placed in there, so they do something with them. But let me ask. I know they do something with them. I don't think it's reused for the classes, because tomorrow's class will get all new ones that you guys did. So I don't know what they do, but let me find out. And let me see how we do with forward interlocking. Maintain tension. We do it. Yeah, we'll focus on the end point of this too, to see how we close it as well. Yes, definitely. Tension on it. Yeah. Nice. That's good. And you can see the shape when you put tension on it, like, okay, cool, it looks like what it's supposed to be. Yeah. Looks like the end point of it is the focus on the end point. And you see your prosthetic is lifting up. That's how you know it's good tension. The dog is off the table. Looks like maybe we'll focus on how to end it. So I'll reverse it now, and we'll go to the closure part, the ending part of it. surgeon's throw, as you'd expect, because it's a tension, to add more tension to it. And he's creating a loop and then pulling it through. So I'll bring up a couple points here now since he's doing it. So if you notice here, and this is the same thing for the previous pattern we did with simple continuous, you see how you have the loop there, right? And so you might notice before for the simple continuous, if you didn't maintain tension, that your pattern gets loose. So what you can do is when you have this loop here and you're about to progress with your closure, you can grab, see how he's grabbing one end of the loop here? And he's pulling it. See, he's grabbing the other end of the loop. He's pulling this end of the loop, and he's pulling this side. So I'll show you again. So here, you grab one side of the loop, and he's going to pull it along with pulling the strand, and then he does the same thing on the other side. And what you do with that is it cinches down. It maintains the tension of your closure. It pulls the entire suture line tighter, and it makes your knot more secure. And then you can continue with the loop and then moving on. The other thing you can do too, either in addition to or instead of doing this like separate, let me go back to it. So instead of doing this where you put tension on one side of the loop and the other side, you can also keep your needle holders open instead of closing the jaw when you're in this loop. And theoretically, if you keep your jaws open, the suture that's over it, that loop, is going to even out when you keep the jaws open. If you close it, the jaws, then it's stuck there. But if you have the jaws open, so here's the jaw open, and now your loop is around it, and you're pulling pressure on it, it'll distribute the stress evenly. So most of us do a combination of the two. We'll close the loop with the open jaws, and we'll put tension on both sides of the loop. See, so this part here, he's pulling the loop, pulling one side, and then he's going to pull the other side. And when he does that, he's also pulling on the tag as well. If you just pulled on both sides of the loop, you'll unravel your suture knot. You have to also put counter pressure on the tag.
Can you show the full closure again?
Yeah. Yep. From the beginning.
No, just like that last little bit before he starts those last.
Yeah. Right here.
Yeah.
Here, let's go with this part. Okay, so he just left. There you go, right there. So he just left the forward interlocking. Turn the needle around. See, you turn the needle around, going the opposite way. See, he's keeping that loop. Keep that loop here. Surgeon's throw, and pulls it through. Then tension on both sides of the loop while you're putting tension on this side. Let me do that again. I don't know who's still working on it. I'll play it one more time and then before we move on. So this is how you end it. Okay, forward interlocking, and then he's going to reverse the needle. This goes till 4:30. Do you guys want to have a break or just keep going? I'm okay either way. Keep going? Okay. We have a bunch of other things we're going to review, so I'm fine either way. Let's do it. So he turns the needle around, bites, goes across, and then when he exits, keeps the loop there. Surgeon's throw, grab the loop, go across. He's going to put tension on both sides, both strands of the loop. So he's going to grab it there, puts tension, while he's putting tension here. See that? It tightens it. Then this loop tightens it, and then square knot, square knot, square knot. And you should, feel a locking pattern through the whole time, but especially towards the end when you're putting that tension on the loop. So this will be inverting patterns. You're really only using this for viscera. So usually 2-layer closures like urinary bladder, uterus, stomach. So we'll talk about this. Some of you may not be doing this if you're only going to be sticking to like subcutaneous tissue and skin, but for those who are venturing into abdominal surgery, this is how you perform an inverting pattern. So there's 2 different inverting patterns, the Cushing and the Connell. With the Cushing pattern, you're creating, with inverted pattern in general, you want to invert them, right? So you're taking bites that are parallel to the incision. So if you notice here, you're parallel to the incision, exit, go across, take a bite, parallel to the incision, exit across, parallel. The Cushing, when you take a bite, parallel to the incision, you're entering split thickness. You're not going all the way into the stomach lumen. So this is the stomach here with the stomach acid, and this is the outside the stomach here. The needle only goes partial thickness. The Connell, you're going full thickness. You're going into the lumen. So most of the time, I would argue that a lot of us are trying for Cushing's, because theoretically, if you're entering the lumen and there's gastric acid here or urine, then those fluids are going to interact with the suture material, could maybe increase the absorption. It could degrade it faster, theoretically. Although, admittedly, we are also doing this to some degree blind, too, because you can imagine as you're closing this like a zipper, you really can't see anymore how deep you're going. So you're going based on feel. But in theory, these are your 2 options for inverting patterns, Connell and Cushing. This is me trying to demonstrate this on the prosthetics. These prosthetics are not the best for this type of closure because this is for hollow organs. It's for viscera, but we'll try. So I'm starting off with taking a bite on one end, going across, bite at the other end, and there I am using bad technique, grabbing the thing with my fingers. Surgeon's throw. Square. And again, you're pretending this is like stomach or urinary bladder. Okay. And then a bite parallel to the incision. Pull it all the way through. Bite parallel to the incision, all the way through. See how it starts to tuck in already? You can see it sink in. You can't even see the incision anymore because it's inverting. Bite parallel to the incision, all the way through. And I'm trying to keep it, see how it's starting to sink in? That's how you know it's going right. It's inverting. It's just appearing on you. I don't care too much about, am I entering it exactly where I left or in between. As long as I'm getting this pattern, see how it's sinking in, that's what I'm going for here. So that's the idea with inverting. See how you can barely see it. So that's the inverting pattern. So you can try that. Again, keep in mind, of course, you have to stay pretty superficial because these are not hollow organs, so you might find it very annoying if you go too deep with your bite. And then I'm ending it. I'll play it again. See the pulling of the suture? So I'm pulling on one end, see that? And then pulling on the other end, and it tightens up even further. See, you can barely see the sutures now. They're all inverted. So I'll play this again. For those who are not going to do stomach surgery or bladder surgery, this may be a bit overkill, but it's still kind of fun to learn it. For those of you who are wanting to enter that or haven't done this before with those organs, this would be your second layer of the surgery. So you would first repair the first layer of the bladder, stomach, or uterus with a simple continuous pattern, and then you would close the second layer with an inverting pattern. Okay, good. I said you can take the big pads home with you because we have enough for tomorrow. So I guess there you go. Yay, just kidding. Emotional roller coaster, sorry. Good. Yeah.
I wasn't counting, are you doing more throws on a longer run?
Nope.
Like
doesn't-
you're not, the same number?
Same number. Yeah. Good question. So the question is, are you doing more throws? The longer the run, the longer your incision, the longer your continuous pattern, are you doing more knots? And no, it's still going to be based on the location of the body that you're working with, how thick that knot's going to be. Those are the factors you're looking for. So no, it doesn't matter. In fact, I don't pay attention to this, but I'm going to assume that it's probably going to be equal with how many knots you start off with and when you end with. It probably just naturally goes that way. But no, it doesn't matter. Yeah, it doesn't matter.
At this point, I'm kind of superstitious about it, but in school they told us if it's interrupted 4 throws, if it's continuous 6 throws, so I still do it that way.
Oh, okay. Yeah, you could. You could. Because obviously we know why they're doing that. With it's going to fail if some continuous knot fails. But 6 sounds like a lot to me. It's not. It's really bulky. Yeah.
I can stop doing that.
Yeah. If you feel secure in what you're doing, then
Yeah.
absolutely.
Yeah, I feel good about the knots, but now, like I said, I'm superstitious. So.
Yeah, no. Try with like a low risk case, and then just work your way up from there. But I will do something like crazy, like 5 or 6. I'm doing again like allergic paralysis is a great example. They have these thick meaty necks and these old dogs, and they're just gross and whatever. And so I'll do that. Or if I'm doing like a lateral suture for cruciate tear, I'm using the lateral suture prosthetic, then I'll do lots of knots for that one too. If I did a intercostal thoracotomy, I've got big knots for that as well. So it's big, thick, like 5 to 7, maybe 5 to 6 throws. So it just depends on where you're working. Median sternotomy, these are also heavy duty cases where the dog's can't stop them from breathing. They're gonna keep breathing, and so I need to have security there. But for the most part, that's very bulky to do 6. Good. How many folks currently perform abdominal surgery outside of like a spay? Do like foreign bodies and okay. And so how many people have done this pattern and the inverting pattern? Yeah, good number. Okay. Cool. Okay, good. Any other questions about this one before we go to another one? Finish this video up and then we'll go to the next one. Yeah.
Sorry.
No, all the questions you want. That's why, let's do it.
I feel like I've been told that
Yeah.
if you want to, because sometimes for like the bladder, we don't want that knot to the original first knot splitting in, that we just start high and then invert on it, right? Okay.
Yeah. So the question is, when you do if I'm understanding correctly, when you do your first layer closure, some continuous pattern, there's going to be that knot in the beginning and the end. And then when you do this pattern, the inverting one, you want to use this pattern to cover up that bulky knot in the first one. Ideally you want to. Because number one, any exposed knot is going to promote adhesions in the abdominal cavity. Number two is it also may interrupt your second layer that you're doing as well. So so typically you're doing simple continuous pattern for your first layer, and then this inverting pattern is starting caudal or behind where your first knot started with the continuous pattern.
Any good advice on how to, just make the end knot not be so big, or like maybe tuck it a little bit too?
If you're doing simple continuous pattern, the question is how do you try to like bury that first knot when you're
end knot now.
the end,
So
yeah.
when you start and then when you come back with the inverting cushionings, so you end up with one knot like at the tip of the bladder or wherever. Any advice on how to make it just so it's not just like this one single thing.
Yeah, the question, any advice on how to like hide that knot at the end of the pattern? I don't have any advice for that, because for me, my solution is I will just start or end my next layer in front of or behind it, depending on what you're talking about. Yeah. And everybody else have I don't think it's that crucial to want to bury it necessarily. And I also want to stay away from anything entering the lumen anyways. I don't want it to get absorbed faster. But I don't think it's a mandatory thing. Yeah. Let's see. Okay, so this is just going to be a quick recap on what we were talking about with the viscera surgery. So I just wanted to remind that if you're doing stomach or uterus, you're starting off with a simple continuous pattern as your first layer. That's what this is showing here. So simple continuous pattern, and this is the first layer. Again, pretend this is like stomach or uterus or something like that. And then the inverting pattern is your second layer that we just did, and this is what you should end up with. This is what you're looking for here. So this is an inverting pattern. So you can see ideally my suture would have been covered, but again, I care, but I don't care. It won't make a big difference for the patient, but otherwise, and this is a very long suture tag. I probably would cut that shorter. And I wouldn't do this. I don't know why we're pulling on it like this. It's crazy. Or maybe that's a state suture. I don't know. It's not my surgery. It's from the internet, so it's solely. Okay, so this time takes some appreciation for the great work you've done so far. We've done square knot, surgeon's knot, simple interrupted, continuous forward interlocking, cruciate mattress, horizontal mattress, vertical mattress. I want to thank PRN again for supporting this talk, this webinar, or the lecture, and Dr. Miller for helping us out. If you want to take a picture of this, my YouTube channel, we're going to go through some more suture patterns now, but this is like the end of the main course that I want to teach. So my YouTube channel will have this video on there. It has other lectures that I've given on there as well. And then thank you again to PRN. Please visit their booth and see what they have to offer here. And so now we'll move on to some other stuff. So this is my bonus material section. So this is showing burying the knot. This is how you want to bury the knot if you're doing like a skin closure. This is usually going to transition to a subcuticular pattern. So it's between the subcutaneous tissue and the dermis. It's right between the subcutis or subcuticular layer. And so this is burying the knot. This will be a very hard thing to practice on these prosthetics because there's no depth to them, but you can still try anyway and just kind of pretend, but I want you to get the idea here because this is what makes the closure really pretty looking, and you can do it for your spays and neuters and any other abdominal surgeries. So the first bite would be considered deep. So you're going into the wound, taking the bite with your needle. This is the deep bite, and then you exit superficial, so deep to superficial, and then you go to the opposite end, now superficial to deep, and then you come out, and so when you come out, you're going to meet the suture tag, and then you tie it, and then it should bring those two edges together while also making sure the knot buries, and so you end up with this. The knot will bury, and then you brought your apposition. You have your appositional pattern now. So deep to superficial to deep. Tie the knot. You're typically going to tie the knot with tension parallel to the incision, not perpendicular, parallel, and that way it sinks into the wound, and you get a buried knot. And so you go from the buried knot. This is the point here. So you bury the knot, and then you're going to take bites parallel to the incision in the subcuticular layer, creating this like zipper pattern. So you bury the knot first, and then you're going to take a bite like this, parallel to the incision, go across, do it again, go across, do it again, across, and that's the subcuticular pattern that you're going to perform here. Yes, that's. I don't have a video for this one, unfortunately, so you have to go based on that. But that's how you bury the knot. Once you bury the knot, you can make this kind of accordion or zipper, and then when you're ready, you can close it the same way that you started it, and that's subcuticular closure. And that makes it for a really nice closure. Sometimes I'll do this, and it'll let me not have to place any more sutures, or maybe I need a little bit of skin glue, and that's it to finish the closure. But it's a really cool way of making the skin closure look nice. It's great for animals that you don't want to see again. you can just have them recheck at home, maybe by like video or on the phone or something at 2 weeks post-op, because there's nothing to remove as long as the incision heals well. For animals that are fractious or nervous, this is a great way. Or if you're doing like catch and release or whatever, that kind of stuff, then you can do subcuticular, and that way there's no need for suture removal. I still recommend an e-collar. I always recommend an e-collar, ideally, unless you're operating on strays, they're just going to be let loose, and what are you going to do? But for these, yeah, it really makes for a nice closure. I think also animals are less irritated by this as well. They're less likely to want to look at it, even though I always use e-collar anyway. But this is a subcuticular pattern that it makes it look pretty. So. Any questions on this one?
Can you go back here to that?
Yeah.
first picture?
This one? Yeah. But yeah, subcuticular closure, bury the knot. This is a good one for skin closures. But don't feel bad if you do the subcuticular on a patient and you find out, oh man, it didn't really oppose very nicely. Then that's fine. Then just go ahead and use your other patterns we learned today to close the skin. It's all right. But if you can get away with this one as your only closure externally, then fantastic.
What do you think about cheating with super glue?
I'm a fan of super glue. Yeah, I'm a fan of skin glue. I think that we do tend to overuse it. You know, you only need a little bit to like get the edges to touch. It does cause a skin reaction, and it can be very irritating, and it looks kind of gross too. But I don't consider it cheating. I think it's great. I think it's great. Yeah. Use it. Just a little bit here and there, and pinch it with the gauze. But that'd be great if you can do some subcuticular pattern and then just a little bit of skin glue here and there to, yeah. I'm also not a big fan of skin staples, although I will use them if the animal's critical. Trying to get them off the table quick, it's dying and critical, and so skin staples, that last layer is fine. I just think that cosmetically it looks gross. It creates like those train tracks, and I think some patients are more irritated by them. The staples rotate and cause irritation. I don't think it looks very pretty. But if it's a critical patient, and rather than have an ugly incision and be alive, than me trying to make a pretty incision and then they don't do as well. So but that's just me for the skin staples. And they are annoying to remove too. But some patients don't tolerate the removal very well. Yeah, it's tough. Yeah, it just broke through. That's all. Yeah, because that's the problem with this pattern. You tried it as well.
Yeah, I just never use it.
It just tears through.
It tears through.
But the knot's down there, so.
Yeah. You get the idea behind it. If you were to do this on a real patient,
Yeah,
it
it's a lot
would be
different.
way easier.
Yeah.
But you get a lot of suture pull through.
It's a lot more satisfying.
I used to get lots of questions for this, so I decided to add to the slides, but these prosthetics they're not meant for that. Maybe the incision that's a curvy incision might be better for these. Maybe it's a bit deeper. The one that's like a S-shaped incision, but yeah, this one might maybe be better. Yeah, so this is a tough one. Okay. We'll move on to the next one. Tacking suture. All right, tacking the subcutaneous layer to the deeper fascial plane, useful for decreasing or eliminating dead space. So what is dead space? Dead space is when there is literally room or space between two tissue layers, and the reason why we avoid dead space ideally is because the body tries to fill it up with something. It usually tries to fill it up with blood or plasma or serum, and when it does that, it not only disrupts the tissue planes, but it also makes it more prone to infection, which turns into an abscess, and you have a whole other problem. So usually, except for some situations, we are trying to eliminate dead space. So here's an example where we are using tacking sutures. Again, this will be hard on these prosthetics, but you'll get the idea, and you can still practice it on here, where he took a bite, he or she took a bite, they went deep and superficial, deep, like we just did with subcuticular closure, but now they want to tack it. So they're going to take a bite somewhere in the meat of the wound, so they take a bite somewhere in the meat of the wound, before they finish their subcuticular knot. I'll replay it. So it's what we just did with subcuticular closure, but they took an extra bite in the middle of the wound somewhere in order to pull those two wound edges even closer together. And that's the tacking suture. So this is a very dramatic example of that, because he or she probably did not need to do the tacking suture. Usually you're using it because you have a very big wound in a big dog, and once in a while you want to tack it to bring the edges closer together. If you do that, it'll put less tension on the subsequent sutures that you place. That's why you would do this. You're not going to tack every single suture along an incision. That makes it really uncomfortable for the animal because now there's no mobility of the tissues. But maybe every handful of knots you place, you do a tacking suture. So same thing you just did, subcuticular. The only difference is we're taking a bite in the wound itself to help with opposing the wound edges. Tough to do on these prosthetics, but if you can try and get the idea. And you can do this as an isolated knot, like they're doing here, or you can do it as part of your running suture. If you were doing like a subcuticular pattern or a simple continuous pattern or something, you can also intermittently tack it and then continue with your continuous pattern, tack it again, continuous, tack it again. So you can tack it as you're doing a running suture as well. But for our purposes, I just want you to be exposed to it in case you've never done this before. It can help you with those really big incisions with lots of dead space that you're just putting a ton of suture in there. This can help you close the dead space more by bringing the two areas closer together. And while we're here, I'll just mention some things. I don't like the towel clamps penetrating the outer drape. You're creating a hole in the drape. Really, this is intended to be for the towels. So ideally, you have 4 quadrants, 4 towels, and the needle holder or the penetrating towel clamps, the sharp towel clamps, are keeping the towels together, and then the drape is placed over the towels and over these towel clamps. So theoretically, you should need towel clamps for the outer drape. But most people, if they're not going to use towels, then they're just doing a drape, and then of course it's loose, and so they want to, but you're creating holes in the drape, just a little FYI. But I know lots of spay neuter clinics will, as I've done as well, they'll just do drapes and then towel clamps and, c'est la vie. But ideally, theoretically, if you're doing it properly, you should have 4 towels with towel clamps at each corner of the towels, and then a drape over everything. Just so you know, just so. Look at all this blood too. Like this is all seeping. So all the bacteria in the skin are going to seep through this, and so whereas the towels would have created a much safer barrier. So, okay, let's go. Moving on. Okay, so similar to tacking sutures, walking sutures. The difference with walking sutures is whereas the tacking suture eliminates dead space, this does both that, plus it creates some level of stretching of the tissue, the skin. So what you're seeing here is they're taking a bite, they're going, this is all deep, so deep to this layer, this is skin, so subcuticular, taking a bite. When they exit this, they're taking another bite in the meat of the wound, but you notice how it's cranial too, it's in front of where they took the bite up here, right? They're not taking a bite down here, perfectly deep to it. They took a bite and they move cranially, took another bite, and then tie it together. So what this will do is this will bring this tissue layer, it'll move it across. That's the idea. It's going to move it across. That's a walking suture. So that's all I have for you for that one. So this and again, hard to do with these prosthetics, but again, it's those big dog wounds where you're trying to bring one tissue layer across. And remember, the goal here is to minimize tension. So by doing this, by putting tension on this area and bringing it forward, even though you're increasing tension here, you're hopefully eliminating tension in subsequent sutures that you place. That's the idea here. You bring it forward. So it's a skin stretching technique that you're doing here. You're doing it in the acute phase. So take a bite deep, exit, take another bite. Now you can imagine if you're doing this in a big dog and there's a lot of tension, you're probably using big suture, probably 2-0, maybe even 0, depending on what part of the body you're talking about and the size of the patient. And you're taking big bites here. These aren't little wimpy bites. These are big bite, and then coming out and big bite, and you're pulling that skin across. So again, hard to do on your prosthetics, but I wanted you to be exposed to it anyway. Anybody use these? The tacking or the, yeah. Walking sutures are great. Same thing, you wouldn't use them for every single time. It would be for certain areas of the closure, just to bring the incision close together.
For the walking suture, are you trying to get it to touch, or you're just trying to get it closer together?
Closer together. So the question is, are you trying to get these two ends to touch, or are we getting closer together? The goal is to get it closer together. If it does touch, fine, but usually I doubt it. But that's also why you're taking bites deep here. You're not taking bites up here. You're taking bites deep. So you're trying to bring these two closer together. And that way, when you're ready to oppose the superficial layers, there's much less tension there. Okay, the Aberdeen knot. How many people have used this before? Jesus, all right. Good. So this is the Aberdeen. So I don't use this, and I don't think I have a reason to, but people love it, and so here we go. He's going to show it. I don't know. I'm talking crap about the Aberdeen knot. Me and Aberdeen have beef, I guess. So here's a slow motion showing the Aberdeen knot. It can be a hand tie or not, but I guess the idea behind it is that it's fairly quick and also fairly secure. But it's slow motion because this is a difficult one to learn, because what ended up happening when I was practicing this one, it would just come apart constantly. So you have to get the tension right for it. So I'm going to play it again. But there's your Aberdeen. Let's play it again.
If anybody knows how to crochet, it's the same principle.
Ooh, crochet. There you go. Yeah. Yeah. There you go. Yeah. Well, when do you guys use this one then? What's your
Spade closure.
Yes.
space for the skin?
The end one on the skin, the intradermal, and then you can just like pop it through out.
Yep, that's what the doctor at my clinic does.
So you do, yeah. Okay.
Wait, sorry, so this, not the lid yet, so subcutaneous.
Yeah,
So
yeah,
you're doing your
final.
intradermal, and then you end it with an Aberdeen, and then you pull it tight, and then you just take it and you put it through the incision to pull it out of the top of it, and then the knot is buried. So you buried it in the lid yet? No? Here, let me show you.
I have another video too of this also that we'll look at.
So you finish your intradermal, and then do you just bury it essentially like a typical bury?
Well, that's a good point. Subcuticular and intradermal are synonyms. So we talked before about pairing the knot and using a subcuticular pattern. It's also intradermal pattern. It's the same thing. Yes.
Would this be fine for like
Wait, so
anything,
that's-
like everything we learned, you're tying the loop at the end, would this be fine for anything you wanted to?
I think it is. Folks who use it? Yeah. Yeah. Yeah.
Makes it look better than tying the loop.
Here's a real example of it. So he's saying superficial to deep.
So you still need two deep to deep knots.
He's saying it's like a French bracelet. I don't have any friends, so I don't have any friends. Sad face. So I'll play this over and over again for folks who wanna learn this one. Yeah, people do love this one. I never got into the habit of using it.
Okay, cool. I get it.
Now, what you didn't see in the other video is this part of it where he's going to bury it. I call it smurfing, right? Smurfing the knot. So you take a bite in the wound, and then you exit in the skin outside of it, and that way, see how it sucks in the knot. So we'll play that. That I do a lot of. I will smurf a lot, because I'm not the best cosmetic closure, so my knots end up sticking out, and so I'll smurf it to get the knot tucked in, a little bit of skin glue, and then we're done. So here's the Aberdeen, followed by smurfing it.
And the speed at which I see my shelter dog do that is
Fast. Yeah, it's much faster. Yeah, yep. Yeah. Yeah. How are we doing with this one? This is one that if you need help with, I'd probably have to delegate. Play it. Yeah. Play it again. I think after this one, we have, I think, our few vascular knots, if folks want to try some pedicle surgery. But the Millers, the modified Millers will be next. And I think, I don't know. Yeah. Yeah. Yeah, so normally if you're using a walking suture, typically your plan is kind of ahead. So you have a big wound, and I'm like, okay, and let's say the easy example is the side of a dog, right? So the big wound here, right? Big wound. So you end up having this like an eyeball, an eye-shaped incision. So the biggest area of tension is the most trouble is the middle part, right? This is as far as the dog's chest and barrel shape. So if you can close the ends, no problem. A continuous pattern, let's say. Now you're getting towards the middle part of the problem. So you close to a continuous on both ends, and then you stop and close them and finish them. Then you take a walking suture or two for the center part to bring it over, and then you can close the rest. Or you can also do the walking suture first in the middle of it, and then do your still continuous pattern. It just depends on your comfort level with it.
What did you put? Not necessarily the incision, but like just the
Yeah. If you can do that without causing a suture pull through, or compromising blood supply, the problem with trying, usually gets times they don't declare themselves for like a day, right? So sometimes it's worth just waiting and see what it looks like tomorrow before you do that. Or if you really do that much fancy like reconstruction, it's better to let it heal by second intention. Yeah, because you end up trying to like do this, you try to do this like perfect intricate closure, and then in 2 days, 3 days, it all falls apart because it was traumatized. Mastectomy is exactly where I end up using a lot of these too. So I've had to do cases where I have like a bilateral radical mastectomy because they have no money. I know, and so I have these two huge incisions, and so like, and you spay them at the same time, so it's like it's a big the whole dog is just one big wound, and so you're trying to, hurry up and make it
my mastectomy's
Yeah.
yeah.
Which is why we don't recommend doing bilateral radical mastectomies. It's too much. It's a lot, yeah. But I've done it because I don't have enough money, and then we just,
We had a question.
Yes.
Do you know why it's called Smurfle?
I'm guessing because the cartoon, Smurfs Live Underground. Do you remember the cartoon? Yeah, that's why I assumed it was called Smurfing. They live underground. They pop their heads out when they want to come out and fight Gargamel. That's what I thought. I don't know. Yeah, I assumed it was the cartoon. I don't know when the cartoon was, when it started in reference to the suture. I don't know. Does anybody know why it's called smurfing? I just always assumed that. I don't know. Dr. Smurf. Okay, so this is, what is this? The modified Miller? Is that what this is? Yeah. Okay. So this is, you use your, if you want to practice this, is for vascular surgery. You've got your tubing. And so you have your rubber tubing, and then the red and white colored string is meant to just help you orient yourself. That's what the red and white is for. It's not, it doesn't mean like venous or arterial or something. It's just to help you orient yourself when you're doing these knots. So this is for pedicle surgery, whether you're doing a spay or a splenectomy or adrenalectomy, a nephrectomy. Some of you may not be doing vascular, some maybe want to start dabbling in more complex ones. And if you don't have anything fancy like a ligature, for example, or hemoclips or LDS, then you can do various pedicle surgeries. And so this is the modified Millers. This to me, I talk about modified Millers before Millers because to me this is easier to learn. So this is the motto, so we'll do it again. That was it, he did it real quick. You have your vessel there, take your suture, wrap it around. And you do this with instruments or hand ties. Just depends on where you're working the body, what your comfort level is. If you're working in a deep part of the body, then either you're doing hand ties, or if you have cardiovascular instruments, like thoracic instruments that are really long, then you can do it that way as well. But very secure. Do it again. Oops. Can't figure this thing out. Okay. So it comes around the vessel. And then stays parallel to it. Goes around again. And then goes around in between both loops and ties it. And then you would place some throws over that for the vessel. How many folks already use this for surgery? Yeah, boy. Yeah, good. That's fantastic. So do you usually perform two, for the side of the pedicle that's going to stay in the animal, are you performing one of these or both of these? One?
One and then a transfixing to keep it on.
And then is your transfixation, let's say this is, where is it? Let's say this is in the body and outside the body. Is your transfixation happening deep to it, or are you doing it outside?
Outside.
Yeah. So your modified Miller's transfixation, and then you're cutting the pedicle up here.
Yes.
Yep. Do it again. Yes, if I'm doing pedicle surgery, for me, I'm doing a transfixation usually, and then I do a circumferential outside, and then I separate. But if you feel more secure with this, or you want to practice this one, this is fantastic. So loop around. And hopefully you can feel the strength when you tie it. Yeah. How are we doing these ones? Saving lives? Nice. Oh, they're stringless. Yeah. play one more time, and then we'll do the what's the next, no, Miller's knot next. I'll give you a little comparison. Okay, so now we have the Miller's knot. So I'll play it a few times here. Go through. You'll see why it's a little bit more complex than the modified, but maybe more secure. See, now he's going across. See that? So this time the loops are not parallel to each other the way they were before. Now the loops are crossing each other. I'll play it again. Nice and easy. Goes between them. There you go. That's the Millers. Play again. How many folks use this one? Not fans, huh? Is it because it's just more complex, or just you don't think it's as secure?
I don't like it as well.
Mm-hmm.
It doesn't cinch as nice.
Yeah.
I tried to learn it and I was just not sure enough that I was doing it properly. I was like, a knot going wrong is worse than, like, maybe this is better, but not if I'm not sure if I did it right.
Yeah, yeah. Yeah, and you're dealing with vascular surgery, right? So you want to make sure you know it's going to work, for sure. Yeah. Oh, for folks who haven't tried it yet, or want to practice it. Yeah. Oops, there we go. Oh my goodness. Maybe one day figure this thing out. There it goes. So around the vessel, and then go across to make the second loop. Instead of parallel, we're going across. Coming through. And now instead of going through both loops, you're going in between them. Do the first loop you created, and then cinch it. And then some more throws after that. There you go. There we go. Yeah, my theory and all this stuff, if you're going to practice different vascular like pedicles, then either cadaver, but obviously you're not going to get any bleeding, or try on like a spay, and that way you have controlled conditions, and you can see whether or not you like it, and then move up from there to more like risky surgery, let's say. Just something fun to try. Play one more time, then we can call it a day if folks have no other questions. Here's my information again. Thanks again to PRN, and thank you guys. Great job today. That was wonderful. Learned all these things. Love all the questions. Thank you. Yeah, if you have any questions, let me know. And yeah, I'll have this video up on YouTube probably the next couple of weeks as the conference ends. But there's lots of videos on the channel on YouTube if you want to explore.